So thanks everyone for joining us for our next Saturday Conversations, Talk with a Doc. We are very honored to have with us Dr. Rebecca Moroose, Director of Cancer Research and Cancer Genetics at Orlando Health, UF Health Cancer Center. Dr. Moroose, once people found out that you were our guest today, I had so many people email me their questions. So we'll try to get to most of them in the time that we have. So let's start with this, with the basics. Should everyone who's diagnosed with breast cancer get genetic testing? And if not, who should?
That's an excellent question, Vanessa. You know, most women who develop breast cancer do not develop it because they've had an inherited mutation. And that's a myth many women are confused about. They think if I don't have a genetic mutation, I'm not going to get breast cancer. Only about 10% of women who get breast cancer have an inherited mutation that confers their risk. So there are guidelines that are constantly being updated that tell us who should be tested and who should not. Basically, if you're at a young age, 45 or younger, when you're diagnosed, you should be tested. If you have a certain type of breast cancer that we call triple negative, that means there's no estrogen receptor, progesterone receptor, or HER2 receptor, up to age 60, you should be tested. If you're of a certain ancestry, if you're Ashkenazi Jewish and you have cancer, no matter what age. And now what's really important, also if you have a family history, a personal history of ovarian cancer, pancreatic cancer, and even prostate cancer in your family is now being added to guidelines. So they've been modified 3 or 4 times in the last couple of years. Also, very importantly, I like to get the message out. If you were diagnosed before 2012, and if you qualified for genetic testing then, you should get retested because we know new mutations and new genes that now are important that we didn't test for before 2012.
All right, so that's a lot of information right there. So let's talk about when we hear the word genetic testing, what are you looking for?
Okay, good question. So what we do when patients come to our clinic, first of all, we look at their personal and family history. And you know, the main genes we know about are BRCA1 and BRCA2, but now there are other syndromes that confer other cancer risks, not just breast and ovarian cancer. So we look at their personal history, we look at their family history, and that gives us red flags to determine what genes should we really test for, because there are many candidate genes. Secondly, if patients don't test positive, we still run risk calculation models that give us their lifetime risk of developing breast cancer, even if they don't carry a mutation.
And you mentioned BRCA1 and BRCA2. I think people are familiar with that. Tell us what that is and what it means.
Yeah, so BRCA1 and BRCA2 are genes that tell your cells to make proteins that help to correct abnormalities or errors in your DNA. So, you know, our cells rely upon DNA to function, and also there are genes that help keep the DNA straight, help to keep the alphabet in line. If the alphabet gets out of line, if they're almost like spell checking, these proteins that are conferred from BRCA1 and BRCA2 do the spell check, and they fix the errors.
All right, so if someone's test comes back and they are positive for BRCA1 and BRCA2, what's the standard course of treatment for them?
Okay, so depending on their age, depending on if they've already had breast cancer or ovarian cancer or other cancers, we then tailor a plan for medical management. So at the very least, for their breast cancer risk, they will get increased surveillance. We'll do a mammogram alternating with breast MRI every 6 months, up until they're 75 or older. Now, as you can imagine, that would get pretty tedious. So many of our younger women will elect to have prophylactic surgery if they have not had cancer. They'll have commonly nipple-sparing, skin-sparing mastectomy with reconstruction. We will also, if they're BRCA1 mutated, between the age of 35 and 40, will highly encourage them to have preventative removal of their ovaries, fallopian tubes, and I also recommend the uterus. If they're BRCA2 mutated, they can wait till between age 40 and 45 to have that prophylactic surgery.
Now, let's talk about this because people don't realize that men can get breast cancer too. So
Hmm.
does genetic testing tell you anything about a man's passing along the breast cancer gene, so to speak, to his daughters?
Absolutely. It's equal. You can receive the gene from mom or dad. Men with breast cancer have a higher chance of harboring, especially a BRCA2 mutation. But many men who carry BRCA1 or BRCA2 don't develop any cancers, so it's not sometimes discovered until a female in the family develops cancer. I want to remind you also that BRCA1 and BRCA2, especially BRCA2, can confer a higher risk of male breast cancer and prostate cancer, and both can increase your risk of pancreatic cancer.
So if that's the case, how about the mother passing it along to her son? Is
Absolutely. It's not sex linked. It's a gene that can be equally passed to mother, to son, or to daughter.
And you touched on this before, but tell us again about this idea of if you've been tested once, you may need to be tested again if you were tested before it was 2012, correct?
Correct. There's two scenarios actually, Vanessa. If you were tested before 2012, we now know there are additional alterations in the BRCA1 and BRCA2 gene that were not being tested for back then. And there are other new genes that have been discovered that can confer various cancer risks. So some patients only got tested for BRCA1 and BRCA2, and maybe they came out without an abnormality. But if it was before 2012, they need that done again. And also there are the other genes that they should be consider being tested for.
And if you, here's a question that came in from someone who emailed us. If you don't have siblings or children, do you need to get tested?
Well, it's for your own personal risk because, as I said, not only do these genes confer a risk of breast and ovarian cancer, but if you had a family history of pancreatic cancer and you had one of the genes, then currently, and this is very new as of this year, we are doing pancreatic cancer screening. So you should for your own personal health. Now, if you're 85 years old, you say, look, I'm not going to do anything about this, even if I test positive, well, that would be a personal decision. That's why it's so imperative that patients who are undergoing genetic testing meet with a board-certified genetic counselor before they undergo testing so they understand the ramifications and the downstream effect of what the results might mean to them.
So what does genetic testing tell us about our family members?
Mm-hmm. Yeah, so we typically can determine which side of the family a mutation is coming from by looking at a very large pedigree, which is a family history. Now, occasionally a patient is adopted or for some reason they're not in touch with any of their family. In those scenarios, we can't use that information. But most of the time, we can get a large pedigree. We like to go back 2 or 3 generations to get as much information as we can. And we can decide what side of the family this came from, and then we need to alert other family members on that side of the family if we do find a damaging or a deleterious mutation.
And when we're talking about other members of the family, how far out does that reach? Is that like cousins or aunts or all of the above?
Yeah, all of the above. So your first degree relatives are your mom, your sister, your children. Your second degree are your grandma, your aunts, your uncles. And your third degree are your cousins. So we like to try to get as much first, second, and third degree information as we can from the relatives.
So if you're having genetic testing, what kind of questions do you need to be prepared to answer?
Mm-hmm. So first of all, what we do at our center is we send a webmail, an email with a private access to a software site where you can enter all your information and it draws your family tree for you. Now, if you're not savvy with that, we can also send you paper information, but mainly we're asking about your personal history as well as your family history. Personal things we like to know about for a woman is the age at which she started having periods, the age at which she had her first child, and if she's gone into menopause, whether she has taken hormone replacement therapy. We also like to know whether she's already had maybe her ovaries removed or had a hysterectomy.
So once that information comes back and you go to counseling, tell us what happens there.
Yes, so the counselor will review your history and decide whether you meet the criteria for genetic testing. If you do, he or she will sit down with you and go over every gene that you might be tested for. And you can select which ones you want to be tested for and which ones you prefer not to be tested for. But they prepare you for the potential results of the test. If you then have testing, then you already know what to anticipate. And I'll give you a great example. There is a gene called CDH1 that confers a high risk of a type of breast cancer called invasive lobular cancer. But it also confers a high risk of a type of stomach cancer called diffuse gastric cancer. There is no good way to screen for diffuse gastric cancer. When it hits you, and it's very lethal. So if a patient tests positive for that gene, we will recommend they have their entire stomach removed. And many women don't want to know that, and men, they don't want to know if they're at that risk because they don't want to go through such a severe type of surgery.
So let's talk about what's new and coming in terms of the field of genetics, because you are working on all sorts of exciting things. So talk to us about what's ahead and what it means for patients.
That's a great question. So we're not only looking for more and more information about the genes that we already can detect, we're looking for newer candidate genes. Also, we're looking for, I'll give you a good example, Vanessa. You can have a family that carries a BRCA1 mutation that's never had ovarian cancer, and another family with that same mutation where all the women get ovarian cancer. Why is that? We don't understand, but we think there could be a constellation of additional genes that are all working together, that are controlling the ultimate penetrance of the cancers that develop in families. So we're looking at clusters of genes. We're looking at things called single nucleotide polymorphisms, which are minor changes in the genetic code that don't actually confer a full mutation, but if you have the, if the stars align, the constellation aligns, that could maybe increase risk. So those are things that we're looking at. And we're looking at ways to treat patients who carry these mutations, not only for prevention, but if they develop cancer. There are now drugs that have been FDA approved that are specific for patients who carry these germline mutations.
So in addition to working with genetics, I know that you're working on this bigger picture too of looking at trying to cure cancer. So
Exactly.
tell us what's new on that front. And I'll just start with a basic question that people always ask. Do you envision a time in our lifetime that we will see a cure for cancer?
Oh, I definitely, well, maybe not my lifetime. You're a lot younger than I am. But the whole explosion of science with the molecular studies that we're able to do, I heard people talking about mammoprint and other things. Well, we're really drilling down on the molecular mechanisms that are the hallmarks of cancer. And once you can see where a molecule has gone awry, you can target that. You might even be able to correct a genetic mutation, or you can target the product of the molecular abnormality and thus more successfully treat the cancer. A great example in my lifetime is the changes we have been able to make in treating patients with HER2-positive breast cancer. Once the most lethal type of cancer, now we have a whole armamentarium of therapies that are targeted that can help those women and put them into remission.
And how about for those who have triple-negative breast cancer in terms of some long-term treatments for them?
Right. So this year, a new molecule was FDA approved for triple-negative breast cancer when it's metastatic. Interestingly, there is a protein that's on, sorry, my husband had to come into the room, and now my dog's going to bark. There's a protein on the cell membrane called TROP2 that's overexpressed in a lot of cancers, but especially triple-negative breast cancer. So an antibody was made that targets that protein, and attached to that antibody is a really potent chemotherapy molecule. We call it the payload. So it gets delivered into the cancer cell, and it's shown very good success with metastatic triple-negative breast cancer in heavily pretreated patients. So that's been one example of where we're going. Also, immunotherapy.
Tell us about that, yes. What is that?
So we know that one reason why cancers can continue to live in the human body is that they're protected from being seen by our immune system. So we understand now how they're protected. And there are certain ligands and proteins that almost put up a shield so the immune system can't see that cancer. Well, now we know how to take away that shield with immunotherapy, with antibodies that are directed to those particular proteins and ligands that are protecting the cancer. So that's been showing some good success and is being studied even in earlier stages of triple-negative breast cancer.
How about research in terms of so many younger women are being diagnosed, women in their early 20s, in their early 30s? What's being done in terms of researching that? Like, why is that happening?
Yeah, I'm very concerned about that, especially Black women and Latino, Hispanic women are being diagnosed, and when they're diagnosed, they often have a higher percentage of triple-negative breast cancer than other women. So that's a great concern. And we are not always finding an explanation for why these young women develop cancer. We have a very young woman in our clinic right now who developed cancer when she was 18, and she does not have a known genetic mutation to explain it. So I think it's the interface of lifestyle and environment as well as our genetic makeup. You know, many women today are more sedentary. Many women don't exercise. Many women are overweight. All those things may confer. We don't know what our other environmental exposures they might have had also. Now, for example, we know that young women who've had treatment for Hodgkin's disease and had radiation therapy to their chest, they have a very high lifetime risk of developing breast cancer. So we know certain environmental things are very obvious, but others are not so obvious. And I think it may have to do with our lifestyle.
So you have been at this for a very long time,
Mm-hmm.
and I know that you have seen so many patients throughout Central Florida. Talk to us a little bit about over the last, say, 20 to 10 years, what you have seen in terms of treatment,
Mm-hmm.
how you would treat a patient 20 years ago, and how if you were treating patients today, all the things that are different.
Exactly. Well, you know, we only had a handful of treatments when I started my practice 34 years ago. We had a couple of chemotherapy drugs, and we had a anti-hormonal therapy called tamoxifen. That was pretty much it. And then, thanks to research, we've developed much better, broader chemotherapy agents and targeted agents, which deliver the chemotherapy to the tumor and have less toxicity to the patient. We've also developed many more endocrine therapies, not just tamoxifen, a whole class of drugs called the aromatase inhibitors, and we've developed other anti-endocrine therapies, including estrogen receptor downregulators, and a whole class of drugs called CDK4/6 inhibitors that work with the anti-hormonal therapy to potentiate the effectiveness. You know, we know the story of HER2 and that tremendous success we've had in treating patients who harbor HER2 amplification or overexpression. And now finally we're getting into the era where we can use genomics. We can do testing on the patient's tumor to decide whether that patient will do better with or without chemotherapy, because chemotherapy is not for everybody. In fact, one study showed that if a patient really didn't require chemotherapy but took that first, you're really delaying her getting the most important therapy, which might be endocrine therapy. So this genomic field is really helping us make decisions, both predicting response and getting a prognosis for outcomes.
How has the research changed in terms of, or I should say, how has the research helped in terms of helping women who have been diagnosed with a stage 4 metastatic breast cancer?
So now we know to classify what subtype of breast cancer they have. If they're hormonally driven, unless they have so much tumor that they're in what we call visceral crisis, which means like their liver or their lungs aren't working, unless they're in visceral crisis, they actually do better to avoid getting chemotherapy and to get potentiated targeted therapy, including anti-hormonal therapy, along with drugs called CDK4/6 inhibitors. We also know we can look for certain mutations in those tumors, and if there are mutations like elevations of certain PIK3CA is a good example, there's new drugs that can actually help that biology. So we're looking at the biology, We're personalizing the treatment for that patient's tumor. And back when I started, anybody with stage 4 disease, regardless of the subtype of breast cancer, got chemotherapy. And then they might get radiation, then they might get tamoxifen or some kind of anti-endocrine therapy.
30 years ago, if we heard someone had stage 4 breast cancer, we would just prepare to say goodbye to them. That is not the case today.
That is not the case. The most challenging stage 4 is still triple negative, and it's estimated that the 5-year survival for those patients is about 20-25%. But with, for example, HER2 positive at early stage, if you are HER2 positive and estrogen receptor positive, if your anatomical stage, based on the size of your tumor in the lymph nodes, is higher, you get downstaged prognostically because you're going to do better than you otherwise would have. So this whole understanding of the subclassifications of breast cancer help us to prognosticate, and then the molecular signatures that these tumors have also give us a predictive, in some cases, as well as a prognostic prediction.
We have a question coming in from someone who's joining in on our call this morning, and it says, do you think a person's attitude plays a role in their diagnosis? And this comes from someone that you know, I think. Her name is Terlisa Shepard, who has been a stage 4 survivor for like 100 years. So how about attitude? Because anyone who knows her is convinced that that's why she is still here.
Oh, I think there's so much that we can't quantitate, but qualify, and definitely attitude is one thing. And look at Terlisa. She's a picture of not just faith and hope, but her attitude is tremendous, and she also helps others and gives them hope. And she's active. I mean, if you know her, she's active. She's in great shape.
Absolutely.
I really think one message that we need to get across, not just to prevent cancer, but for women who are going through treatment and then afterward, is exercise. Exercise trumps everything you can do. You can be skinny but not exercise, or overweight and exercise. Exercise is the most protective thing over weight. So I really am a proponent of that. As you probably know, I'm a breast cancer survivor, and I finally got my act together after that. And you know, it's difficult when you're a busy woman, a mom, having a job, whatever is going on in your life. It's really hard sometimes to put the time or find the time to exercise, but you got to do it. And once you do it, you'll get hooked on it, and then it will perpetuate.
What excites you the most about your work that you are doing now?
Oh, it's the patients. It's always the patients. I mean, I love, seeing people I might have treated in the past and see them doing well. I love when a patient goes on a clinical trial and he or she gets a response. I love seeing a drug go from the very inception of a hypothetical molecule all the way through being approved by the FDA so it can help patients. That's really exciting. And in the genetics world, I love being able to empower patients to maybe avoid cancer, to do what is in their power to avoid developing a malignancy depending on what their genetic mutation might be found to be.
Well, before we go, do you have anything that we did not ask that you think is important for a message for patients and potential patients?
I think every woman, whether she has a mutation or not, needs to understand her personal risk of breast cancer. And I think that's very important because, as I said, only 10% of breast cancers occur because of an inherited mutation. So 90% of us are getting cancer, and it's not because we can blame it on a mutation. So everyone needs to understand their personal risk.
All right. Dr. Rebecca Moroose, thank you so much for joining us to talk about research and talk about genetics. We appreciate it.
Thank you for doing this, Vanessa. My hat's off to you. You're such a great advocate and such a great example, as are the other members in your audience. Thank you.
Thank you very much. And all the people joining are applauding you, so we're happy to see you.